tendency for the occlusion to break. It moves in an opposite direction. Venting happens from the fluid management system so that the pressure buildup that is there in the aspiration tubing is not there, and because of which the surge is mitigated to a very large extent. So I feel that, already we had an excellent system, a robust system. What has happened is the active sentry, it has got further enhanced. And at the end of each surgery, actually, you can see how many times it has got actuated. You got what's called ASM, active sentry numbers. And this tells you how many times the occlusion was about to break and how many times it came into play, making the surgery so much more safer.
Now, with this active sentry advantage and the balance tip advantage of this Centurion machine, do you feel that you would still want to have that IP thing activated in your cases? Especially this, did you have
I always have it active because I think they serve two different purposes.
Yes.
When it comes to sculpting, when it comes to chopping, I don't have the IP activated simply because we want a good hold on the nucleus fragment. But when it comes to nucleus removal, the fragment removal, the IP essentially gives a small burst of longitudinal phaco so as to reposition the nucleus fragment right on the phaco tip. I think they are for two different reasons. I still would go ahead and use the IP.
And how do you feel Centurion has a huge advantage, like in a high myope, for example? How would you feel so?
Oh, as you could see, I could use 30 millimeters of mercury pressure. And when it comes to a high myope, I use usually 20 millimeters. And then still I can go ahead and use an aspiration flow rate of 34 or so, vacuum of 550, and have an extremely stable chamber. So I believe in this vitrectomized eyes, in myopic eyes and all, it's definitely an advantage. Okay.
Rajesh?
Yeah, 20 with 35. I mean, this combination is really, I mean, hats off to you to manage that combination, because at 20 is really commendable. You never get any surge. As you can see, you have the active sentry which prevents that. But yes, it is something which is really good, and that will definitely help the patient.
Especially a high myope, no?
Yeah, particularly in high myope, wherein you can have, chamber fluctuation.
Yeah.
Even have a breathing pupil kind of a thing because of chamber fluctuation. All these things can be, obviated if you can keep such low bottle height, I mean, such low intraocular pressure.
Yeah. Especially the kind of vitreous syneresis which is there in these eyes, these IOP fluctuations would be quite deleterious to the posterior segment.
True.
Yeah. Shall we
but definitely it's commendable because, to keep it at 20, you have to, since you are doing it every time on 30, so that's why you can still manage at 20. With somebody who is doing it at 45 or 40 or 50, then for him to go down to 20 will be difficult. Down to 30, 35.
Routinely, you can actually do it at 20, but then the eyeball feels a little soft.
Yeah.
So that's the reason I keep it at 30. But when high myopes, when the chamber tends to deepen too much, I bring it down to 20. Yeah.
True.
How do you feel Vivity is more forgiving with the as compared to the other extended depth of focus? Do you feel there's a difference?
Basically, the science of this lens itself is different in the sense that it's supposed to be a wavefront guided technology, X-wave technology, where basically there's no diffractive rings. It's just a central 2.2 millimeters, as I was trying to explain on the table also, where there is a slight modification and there is a what they call a surface transition zone 1 and zone 2, because of which there is a spread and surge of the light rays that is coming onto the lens, and because of this, it acts as a EDOF lens, and it's almost equivalent to a 1.5 to 2 diopters, and there is no dysphotopsia, simply no glare or halos, simply because there is no diffractive rings in this lens. But of course, there is a slight drop in a modulation transfer function compared to the conventional monofocal intraocular lens, which is barely imperceptible. And especially if you do a slight bit of micro monovision aiming at a minus 0.5 diopters in the other eye, bilaterally implanted, majority of these cases are do well for all distances. Having said that, as far as near vision is concerned, this lens is still a little deficient, but intermediate and distance, it does very well, especially when you take care of the cylinder also.
Yeah, actually, compared to any multifocal, there is no splitting of light which occurs here. No splitting of light, and again, you don't have the disadvantage of the diffractive technology. So put together, definitely it maximally utilizes light, and you are able to do well right up to 1.5 to 2 diopters. And I think it is one more huge advantage which has come in the extended range of focus, and I'm sure we could use it for all those patients who are, having some kind of a posterior segment pathology where you don't want to lose out on a contrast sensitivity. In those kind of situation, I think Vivity would have a major role play. And Rajesh, on your experience, they say that sometimes you want to make it a little minus, so you would err to put a little plus powered lens in these eyes?
Yeah.
Yeah.
Yeah, actually, this is an option. One can go ahead and maybe implant the target refraction. You can keep at maybe minus 0.25, minus 0.3. That is really, very helpful in improving the near vision. And the patient is also 6/6 partial. So that way, bilaterally, he will be 6/6 and N8 or N6, something like that. So that is what I prefer. So that, bilaterally the patient will be 6/6 because he may be 6/6 part, but near vision also is very good. So in one eye, if by one eye is N8, even bilaterally also, if he is N8, then the purpose is served. He will not require any glass.
Yeah.
I had a question, Chitra, both for Chitra and for Dr. Ramamurthy. If there is a patient who has a EDOF of some other company, would you mix and match Vivity with it?
See,
will it make a difference or it will not make a difference? And point number 2 is, if it is a monofocal in one eye, I think we discussed this again and again, would you put a EDOF in the fellow eye like a Vivity?
See, the issue with the EDOF lens, which was commonly available to us, again, was that as far as near vision was concerned, it was slightly deficient, was a very good lens for distance and intermediate. But then that lens was essentially on a diffractive design. So as far as the glare, halos, dysphotopsia is concerned, that could often mimic the conventional diffractive multifocals that we have experienced with. So because of that, if the patient is coming to me saying that the near vision is a little deficient for me, and that's what I want, I would rather go ahead and put a trifocal intraocular lens or put the same lens with a slightly higher power, aiming at a slightly minus residual power, which will take care of the near vision. But if the patient came to me saying, I'm not happy with the quality of vision, dysphotopsia is what is bothering me, but I'm reasonably happy with the intermediate vision, I want something similar or something better than that, then I'll go ahead and put this Vivity or Vivity toric intraocular lens, which will give him fairly good intermediate and near vision also. But at the same time, the quality of vision is likely to be much better, simply because though this is approved as an FDA approved EDOF lens, it doesn't have the diffractive rings, because of which the dysphotopsia is not an issue with this lens.
Yes, I do agree entirely. It's the dysphotopsia which is a bother in these multifocal lenses. And when you use this extended depth of focus lens in the other eye, if the patient is disturbed by the dysphotopsia, I think this would be an advantage. And if a patient is happy with the near vision in the dominant eye which is operated, but he wants some more clarity of vision for distance and some advantage of intermediate, we could do it. I don't think going mixing match with two different optical principles will be a disadvantage if the one of them is not a diffractive lens.
Okay, just one more question from my side. If, what is the size of the central ring that you showed?
Basically, it's 2.2 millimeters is where that surface transition zones are there. That outside there is a ring which is just about 1 micron elevation, while centrally there is a slight optical changeover. The exact what exactly happens there is, I think, proprietary information, because of which it's supposed to stretch and spread the light, and because of which right from intermediate to distance you get a good focus right through. So unlike the other lens, which is somewhat similar to this, that's essentially a monofocal from the other company. It's a monofocal intraocular lens, approved as a monofocal intraocular lens. That's the reason they did not have to go through the regulatory process. And it also works quite well. and many of us use it as an alternative monofocal. But this is truly a EDOF lens, because of which you get the advantage of almost a 1.5 diopters of watt power, but at the same time, the dysphotopsia problem is not there.
The
The
way I
reason why I
understand
asked this
is,
question, yeah, Chitra, the reason why I asked this question was that I wanted to know whether, angle alpha has a role to play in it or not. If it's more than.
no, I would want to add one more thing to the technology. As I understood, I may stand to be corrected. The light comes to the peripheral light and the central light is the wavefront gets split. So the light which comes from the periphery ensures there's a great distant vision. And because that the central wavefront of light comes more slowly, this sort of stretches the wavefront and gives it a little more of that intermediate vision also. So a little more depth of focus. And by the time the central wavefront of light adds on and gives it a little more nearer focus. So overall, that is why they call it a stretch and shift technology, wavefront technology, based on which is able to reach out to a greater range of vision. Again, I am totally buying into what I've heard and understood.
I think you've understood correctly, Chitra.
Yeah.
Yeah.
So could we move to the next case, please?
Yeah, we can go on to the next case, sure.
Thank you. Thank you very much.
Thank you so much,
Thank
Raman.
you.
It's always a pleasure to watch your surgeries. Always.
Thank you.
So we have another very accomplished surgeon, and I think Dr. Sirish is operating now.
Dr. Shreyas is operating.
Shreyas is operating.
Okay.
Am I audible, madam?
Yes.
Yes.
I think we have
Good afternoon,
already...
Namrata madam, and good afternoon, Rajesh sir. It's really
Yeah, good afternoon, Shreyas.
operating in front of the two of you. And
Very happy to see you doing live surgery.
thank you, sir.
You are operating in front of many ophthalmologists, members who are watching you. And I'm sure, Shreyas, you're going to do a great job.
Thank you, madam. So this is a fairly straightforward NS2 to 3 with PSC cataract, and I used intracameral lignocaine first, and just a little bit of trypan blue for better visibility. And this is just a regular HPMC going in. It's a slightly shorter eye, 21 axial length, and planning a Acrosoft IQ Panoptics for this patient. So again, using the Varion overlay to ensure I have about approximately a 5 mm central rhexis. So I go in the reverse direction, as you would have noticed, compared to what Dr. Ramurthy did for his rhexis.
Yes, I was about to comment on that, you're going. But I think whatever you have learned and whatever you are comfortable with is the way to go.
And so just to get a more triplanar incision, I use this 15 blade for the initial plane, and then the entry with a 2.2 keratome.
Could
So
you
you
be
prefer
louder,
2.2?
2.2 or 2.4, sir. Either way is
Okay.
I'm quite comfortable. Actually, 2.4 I do prefer primarily because it does make life a little easier to implant all types of lenses. I mean, for the Panoptics, it actually with the 2.2 also it's quite okay, but some of the lenses 2.4 is easier. So just a gentle multi-quadrant hydro. Just keep tapping on the lens each time. Also with the 2.4, especially with harder cataracts, we notice that the wound burn is also a little lesser. So again, wound burn is not as common even in grade 4, grade 5 cataracts with the equipment we have today. So
what instrument are you using to dial your lens?
Just a regular Sinsky, madam.
Okay.
So you'll be using the same balance tip?
Yes, sir. The same balance tip, sir. And this is about a 1.5 mm chopper that I'm using for this case.
Do you use different size choppers depending upon the hardness and thickness?
Harder cataract, I prefer the longer choppers, sir,
Mm.
even 1.75 or so. So after just clearing the epinucleus, just embed into the nucleus.
Very nice.
Just a simple direct chop and
Yeah.
just rotate the nucleus around. Ensure that it's separated right up to the
Yeah.
center and then
Excellent, Shreyas.
Truly, actually, this is also the first time I'm watching my son operate.
Oh, oh no, he's doing a
Good one.
wonderful job. Absolutely effortless. And we have a lot of people watching on the YouTube. Already so many views, as well as on the Facebook. And we are again thankful to the I Foundation because so many people who would have actually wanted to come there and watch are actually watching it right from their own, laptops and iPads and mobiles. So thank you for that.
Yeah.
so I
We-
prefer to do a little bit of hydro delineation also in most of the cases.
Can you be
It
louder?
helps-
Mhm.
It helps in ensuring that even right up to the last piece, you have that epinuclear cushion to ensure that your phaco is really in the bag,
Mhm.
and helps in the softer cataracts, especially if you're not able to get a good chop, to ensure that you are able to cartwheel the nucleus out. So that's why this is the epinuclear sheet that you're seeing, which can then be easily removed.
So do you shift to the epinuclear mode which this machine has, or you keep continuing on the same and
I continue on the same mode, madam.
No, I would prefer to go to the epinuclear mode because I think that much is enough at this point. But we would ask Shreyash about these parameters once he completes his case.
So I think this is the control of the machine. You really actually don't have to do anything. Just remain in the center and everything dynamically flows towards the phaco tip.
Yes. Yes.
Absolutely, madam. And frankly, it's been a long time since I've changed settings for any grade of cataract. I mean, we've even stopped looking at our settings. Just now, Dr. SK and I were having a chat before this case, and we were looking at the parameters primarily for this meeting in case you ask any questions.
Okay.
Because all grades of cataracts nowadays, we are able to manage with the same settings. And I think that's really credit to the kind of stability that these machines are able to give us.
A little bit of modification can be done by your good foot control as well. So
Yes,
that-
sir. Yes, sir.
Yes.
And everything is in linear mode, sir. So it's really, we can call upon more power, more vacuum whenever necessary, and not necessarily have to change settings too much.
You also do hydroimplantation of lenses, or you do under viscoelastic?
I use Visco, madam. So
Actually, Namrata,
will
I also
cleanse you.
largely used Visco for years and years.
Yeah.
Last time when we saw in Partha's place,
Yeah.
hydro implantation.
Yeah.
After that only actually I did my first
Okay.
hydro implantation. But
Okay.
now I really like it. I mean, it saves a lot of time and
Yeah.
makes things so much easier.
now, one of the reasons I don't use hydroimplantation as much is because I prefer using a screw type injector, madam. So that requires both hands to
Yeah.
implant the
Okay.
lens. Somehow I
Okay.
feel it is always much more controlled with a screw type injector. Push type, sometimes you have the sudden jerk in implantation. I've had a couple of cases of misfortune in a toric IOL where that sudden protrusion goes and hits the PC, even causes a small PC tear. So removing,
It's just a matter of that
behind the
extra
lens
1 minute.
and,
Nothing.
remove the
nothing else.
viscoelastic. That's
Yeah.
the only extra step that is required
Yeah,
when you're doing viscoelastic. But then it's just a few seconds extra, and somehow I find this very comfortable.
Yeah.
Centering of the multifocal lenses are important, and as you can see here, it should be centered on the rexes. as well as the Purkinje image, which you can see on the lens, which should fall exactly within the center of the circle. I hope it's visible.
Yes, it is visible.
And
I think we could ask this question, which Rajesh you had to Shreyas. Now, with the modern multifocal technology, do we actually need to bother about angle alpha, Shreyas?
I think definitely we have to look into angle alpha. I mean, I would definitely not say angle alpha is not required.
No.
Yes, I do agree that the results are a little varied. We have looked at patients even while we were doing a study comparing EDOF lenses with trifocal lenses when it was first introduced in the market. And we found that there were quite a few patients with a slightly higher angle alpha, but still it did not correlate with the subjective symptoms as far as glare, dysphotopsia, and other things are concerned. But I would definitely suggest that we do look at angle alpha on a regular basis. And if it is very high, definitely keep it in mind. Whether it's an absolute contraindication, I would not go to that extent, but definitely something to be kept in mind.
So my thought process was, I stand to differ. My thought process was that the optic zone, which are being used for lenses like phaco, fan optic, synergy, are larger optics, like central optic is, yeah, I think we'll come out there.
Thank you. All the best, sir.
Yeah, actually, it depends on the central ring.
Just 1 minute, Rajesh.
Yeah.
Let's get a young hero into focus.
Chitra wants to put him again in the firing range.
No, not the firing range.
Actually,
so effortless.
No, she is so protective. She will take all the fires on herself.
No. Oh, he'll be so calm through it. It's just that I feel that with that central zone, which is now larger in these present day multifocal, like Panoptics, I think has 1.14. Synergy has. So it is, I understand that even if the angle alpha goes up to 0.8, it would be forgiven by these multifocal Aios because of the central large zone.
Slightly differ. So I will slightly differ on that because 0.8 will be too high for
yes, sir.
zone of
0.5 would be a sweet spot, especially
if it is 2
because the
millimeter
diameter
zone.
is about 1.1 mm or 1.2 mm. The half a millimeter would be the maximum I would also think about as far as this.
So Chitra, Shreyas has corrected you half a millimeter.
No, that's okay. But the other question is, now when we are talking about non-diffractive technology and all, how is it Panoptics? I do not have my patients complaining of dysphotopsia with Panoptics. And what could be the reasoning which each of you have derived through your practice, and what do you say?
I think, yes, madam. I think I wouldn't go to the extent of saying there is no dysphotopsia, but definitely the dysphotopsia is less. And essentially, one of the reasons why dysphotopsia happens is because of the stray light. And, better the energy utilization, light energy utilization by the lenses, lesser the glare and halos. In fact, initially there was thought process when trifocals were being introduced that you would have more glare and halos than bifocals because of the extra set of diffractive rings. But that was not found to be the case. In fact, it is slightly lesser than the bifocal diffractive lenses. Essentially, Panoptics utilize 88% of light utilization happens with the Panoptics. And therefore, there is, because of the high light energy utilization, the stray light is lesser, the incidence of glare, dysphotopsia is lesser. That is one of the primary reasons why patients are quite happy. Of course, there is some dysphotopsia, definitely, but they are able to adapt to it quite easily.
That's brilliant. That's the answer. The other thing is, what is this? The guys keep talking about enlightened technology with the Panoptics. Could you enlarge for the audience?
Which is their proprietary.
Yeah.
As madam said, it is proprietary. So there's only so much that we have understood or know about it. But the idea is that essentially, if you look at any diffractive technology, the distance of your near and intermediate is determined by the first ring. So essentially, half of that ring is the distance of your intermediate vision. So now, most of the earlier trifocal lenses were having somewhere between 70 to 80 centimeter as the intermediate zone. However, that is slightly beyond the range of a normal person, especially in our population. Let's see, where the average height is maybe a little less than 6 feet. 60 centimeter would probably be the more convenient distance for intermediate, where we would keep our computers or cell phone. So now what happens is this uses something called a quadrifocal technology, where essentially, let's say there are 3 overlapping rings, starts with a 120 centimeter and then goes down below. So that 120, the half of that 120 becomes the 60 for the intermediate. And then what has been done is that the light energy for that 120 has been truncated and changed for distance. So essentially there is no ring for 120, but we get the intermediate zone for 60 and then the near for around 40. And that 120 is then sent to distance. So this is what they call as enlightened technology as such. So primarily to bring the intermediate down to 60 and as well as utilize the light energy as well to a greater extent, enhancing the amount of light energy being used.
Having
Very nice
said-
description.
Very rightfully said.
Yeah.
Yes, Chitra?
No, having said that, what do all of us feel comparing it with the other trifocals? Like I do believe that Panoptix is 60. Do you think that itself stands an advantage, or the other trifocals are also forgiving?
I think they are forgiving. I don't think too many patients complain of poor intermediate one versus the other, but this is the science behind bringing it down to 60 centimeter rather than 70. But yes, having said that, do patients really complain a lot? Maybe not as much. But after having these intermediate, previously we were very happy even with the restore lenses, the diffractive bifocals, thinking that patients are very happy. But now I do see patients with when we implant a bifocal multifocal versus a trifocal multifocal, you do see bifocal multifocal patients saying that, while I can read well, my computer vision and cell phone is not as good. So I think definitely trifocals are the way ahead. Whether it is 60 or 70 maybe matters less, but definitely trifocals are the way to go.
What about this 4.5 millimeter magic diffractive zone they claim?
So it is probably a sweet spot between being pupil dependent and pupil independent, having a right compromise without compromising, without affecting your distance mesopic and distance cotopic visions. So 4.5 millimeter is the diameter to which the rings extend in the Panoptix lens. So it becomes less pupil dependent. So even in patients with slightly larger pupils and smaller pupils, it can be used both ways. Of course, smaller pupils, it would not make much of a difference, but even with slightly larger pupils, you will do well even with this 4.5 millimeter.
So I think Shreyas, you have clarified everything so well. Surgically, of course, it was so effortless that we sailed through it even when we spoke one sentence and it was, all neatly done. Yeah. And also explain everything so well about the Panoptix vis-a-vis other lenses of similar technology. So
I think you have fully satisfied our
fully satisfied our sponsors.
we don't have any more questions. Yeah. And can we move to the next case? Thank you, Shreyas.
Thank you, madam. Thank you, sir. It was a real pleasure. Thank you, sir.
Shreyas.
Thank you, madam.
Yes.
Next, we have Dr. Shreesh Kumar, a very accomplished and a very dexterous as far as the surgery is concerned, both cataract and cornea. We have seen his corneal surgeries as well as cataract surgeries both. And over to you, Dr. Shreesh Kumar.
Thank you, Dr. Namrata. Thank you, Dr. Namrata. Thank you, Dr. Rajesh. So it's a grade 2, grade 3 cataract with the dense PSC, and the patient is a 60 years old male. And I am using a Centurion vision system, again using the active fluidics. This is a kind of நடுல பாருங்க லைட் பாருங்க
You're
He's
going
going to be showing a clarion implantation.
I am going to show a clarion implantation using autonomy, which is a new automated delivery system. I usually make a limbal incision, and I usually give a small cut in the periphery so that it will not cause ballooning of the conjunctiva.
Okay, so you preemptively give a neck in the conjunctiva.
Yeah.
So you don't go for a clear corneal, you go for a limbal incision.
Yeah, I usually go for a limbal incision. For clear corneal, of course, it's not needed. Yeah. And then I inject lignocaine intracameral. I stay in the capsule. Nadula paranga.
So you will have to center it a little bit.
Yeah. It's a slightly intumescent cataract, and the anterior posterior diameter of the lens is around 5 millimeters. Nadula paranga. And the AC depth is around 2.5 millimeters.
Okay, so you mean the lens thickness is 5 millimeters?
Yeah, 5 millimeters.
Okay, so it's a thick lens.
Yeah, thick lens, it's an intumescent lens.
Yeah, that's what I meant. Intumescent.
Try to make a slightly smaller axis, not going to the periphery, maybe around 4 millimeters.
I think that is the way to go, especially for an intumescent lens, which already has a raised intralenticular pressure, and chances of rexus going to the periphery are really high.
We do multi-quadrant hydrodissection.
Just a thought, Rajesh. I believe just one spurt of hydro in the right plane is enough. I normally never go and inject more and more unless it's a soft cataract and I would want to hydro delineate. Would you also believe in multi-quadrant hydrodissection?
I mean, it is variable. Like if you just put one spurt of fluid and it goes behind creating a wave, then just a tap on the nucleus is enough.
Yeah.
After that, so it spreads the fluid all around. But sometimes it doesn't happen, so you may have to do 2-3 full quadrant hydro.
So I believe in a multi-quadrantic hydrodissection and multi-quadrantic hydrodelineation also, because I just feel that softens the nucleus, dislodges it, and
We do a direct chopping technique, direct horizontal chopping. It's not a hard cataract, it is a grade 2 cataract.
Yeah, but a swollen lens.
Yeah, swollen lens.
So you are also using active sentry, Shrish? Or
Yeah, I'm using the same system. This is active sentry, and I don't use such high parameters as Dr. Ramamurthy had used very high parameters, high vacuum and low this thing IOP. But I use 55 IOP, and my vacuum for nucleus chopping is around 300. Now for quadrant removal, it will be around 400. and use only torsional power.
Okay. Even after chopping into multiple pieces, you don't use.
Yeah. 40 vechirukka.
So for a cataract like this, what would be your torsional power that you would be using? I mean,
Yeah, for the first stage, it is around 40. And for now, for quadrant removal, I use around 50, 40 to 50 as a torsional power.
Yeah. Yes. I think the foot control takes care of the changes
Absolutely.
which happen through the surgery. That was one question which I wanted to ask Shreyas also, but he himself answered. And I do believe that a certain level of comfort in surgery comes. We actually don't have to play around with the parameters unless it's a floppy iris or a very shallow anterior chamber, when you would like to bring down your parameters even more.
Now we use both gravity assisted IOP and even active fluidics. So we're comfortable using these moderate parameters.
So for these, do you use epinuclear mode or you continue with the same mode?
Same, yeah. This is the same FACO 2, that is a emulsification. Yeah.
now what was the size of your incision?
Incision is actually 2.2.
Okay.
Yeah, so I might enlarge it slightly to inject the lens, which is it will become too tight because of the hydration, and there's hardly any cortex to aspirate.
Yeah.
There's hardly any cortex.
Yeah.
Yeah. So I'll be using a new injector system that is called Autonomy. And could you focus?
I think this Clarion lens is also on a different platform, and the supposed to have less glistenings as opposed to the previous
I'll load it.
platform.
Can you just
yes.
focus on this?
Yeah.
Yeah.
Can you focus from outside?
Focus on the.
There's a new injector system.
I think you'll have to decrease the zoom, then it'll get focused better. Just decrease the zoom. Yes. Now we can see the entire injector.
Yeah, this is like the shape of a handpiece, and the weight is also almost the same. And it has got the visco port as Alcan visco. Visco. And so this is a visco injection port.
This is Risolon that you're using, I mean HPMC?
Yeah. Yeah, actually they suggest Alcan qualified visco, either a viscoat or a disco visco, and fill it to the brim. You can see the visco going up to the brim.
Yeah.
This is the nozzle.
Yes.
And there's a guard. So this is the portion which is going inside the eye. And you have a locking system here. And this is the, so in this you have to press to release the carbon dioxide. So on the rear side, there is a chamber called a carbon dioxide cartridge. And once you press this plunger, the carbon dioxide gets released. And it's a carbon dioxide powered injector system that allows the plunger to move forward. So I'm going to release this now. And going to press this plunger, and you get a click. Yeah. Once this is done, the system is ready for injection.
You want to increase the incision size?
I will try with the same. This is 2.2, and you have a grip on either side. So this is a grip. So you hold it like a pen. This is a grip. Hold it like a pen, and you press on this speed changer. There is the plunger here. Yeah. And now you press on this. You can see the lens moving forward
Yes.
slowly, and yeah, getting injected into the anterior chamber.
That was a very graceful release.
Yeah.
Yes.
So Chitra, if she says it's a graceful release, that means it's one.
It's actually a small
Very-
axis. I
Yeah,
have to
very
manipulate
elegant.
it.
I think we moderators need to pat each other's back for also having traveled far and yet being there for these heroes to do
Yes.
their surgery.
Yeah. What time you reached?
Look
I
straight.
just reached
Nera paranga.
Okay.
about just in time. My flight landed at 4.
Okay.
So I think the best part about Clarion is the material which they have
The
changed.
material of
Yes.
the lens. It is
Yeah.
modified hydrophobic acrylic where they have added HEMA to the existing hydrophobic material and to reduce the glistening. So this is actually available now. And soon I think they are going to come up with the Clarion platform for all the premium lenses from Alcon. That is Panoptics and Toric. So it's going to be Clarion Panoptics and Clarion toric lens from Alcon.
Actually, what they have done is, again, we've been told that water content, which was 0.4, has been stepped up to 1.5%, which has reduced the glistenings in these lenses.
I go
But,
behind the lens.
But personally, I have never felt that the glistenings are actually a visual disturbance. Are they?
No, sometimes they can be, but I think most of the time they are not. Also, I think with these lenses, negative disc photopsias are much less as compared to the other lenses
Yeah.
the same platform or from different platform. I only feel that it is priced a little too high as opposed to the original platform that we had.
Yeah.
And if they are planning to shift everything on this platform, then I hope they would be.
The price will come down,
price.
but a lot of this thing money has gone for this injector system. Like it's such a nice injector system, automatic.
It's
I
nice,
think-
smooth, and you can implant it very well through a 2.2 millimeter incision. So
Yes.
all the things are there.
Yeah.
So
I
theoretically, microbial contamination is also less with the preloaded lenses as opposed to the ones which you have to load.
Yes. I think we can take one odd question on the Clarion with the Shrish, once he injects intracameral xylocaine. I'm sure you all must be using it in all your cases. Moxie. Not xylocaine, intracameral, moxifloxacin. Yeah.
Intracameral
Yeah.
So we just concluded a trial of 17,000 patients with and without Moxie, which is a randomized study, and we have we are now analyzing our data and coming out with the findings soon.
Okay, sir. Fine. Good.
In fact, it's going to be the first RCT on moxifloxacin intracameral, because although we all know, we all use it, but the data that is available as of now, up till now, is only on retrospective cases.
So I think Shrish has done an truly amazing surgery again, and with absolutely no drama to it about parameters or phaco and all that. It's just straight and simple, elegant surgery, and he's done it. So I think, Rajesh, you have any questions to ask about the surgery, or shall we go on to talking about the the Clarion parameters.
I think we can
Clarion
Actually, his
behavior.
surgery,
We can talk about the Clarion.
his surgery was as smooth as the injection by Clarion. So everything was very smooth. So nothing, no question for the surgery. It was perfect. So let's have more information from him about Clarion.
Just one comment I have, because this discussion about the incision size came up.
Yeah.
Along with the active sentry, apart from what we discussed about the very stable anterior chamber, we also have this leakage compensation incorporated. There's a patient eye level. And because of that's the reason that whether we use 2.2 or 2.4 millimeter incision, there's an automatically inbuilt leakage compensation which takes place. So even though there might be some leakage from the through the main port or even through the side port, the intraocular pressure remains at 30 or like they kept at 55 constant, and you have a very stable anterior chamber.
Yes. And
Difference you found out between 2.2 and 2.4?
what did you?
Sorry?
Any difference you found out between 2.2 and 2.4?
No, Rajesh, actually, I was for at least 2 decades, I was using 2.2,
Yeah.
and there was even a phase when it was fashionable to go sub 2. I even tried doing that and all. But then I realized that when I make a 2.4 millimeter incision, whether putting my cartridge and injecting any type of intraocular lens, as well as the phaco needle going through, is also flawless. There's no crimping of the sleeve, etc. And also the significant study came up which showed that if it's a clear-cut temporal clear corneal incision, whether it's 2.4 or 2 millimeters, the centroid value of the astigmatism induced is less than 0.1 diopter. So there is really no need to go ahead and try to tighten up your incision. So I have last couple of years, I shifted over to 2.4 and 2.2, and I have always never regretted that decision.
Like for my flax, I have always used 2.4 millimeter incisions. But normally, otherwise, I do 2.2. So I never felt the difference, and always found that both are good, actually.
I think
I am a little uncomfortable increasing the incisions. I always go for 2.2. And although not.
But for flax, what's your size of incision?
For flax, it's say 2.4, but otherwise conventionally it is 2.2. And I know of preloaded systems which go very well with less than 2.2, also as small as 1.8. So that way, I don't know. I mean, I really don't know whether you should increase the incision slightly for these lenses, because they can go by 2.2. But I think Dr. Ramamurthy rightfully pointed out that you would have to in some of the cases.
Yeah, and I think there is one other advantage with the Clarion as far as their claims for less dysphotopsia.
Yeah.
Shrish, would you want to add something on that?
Yeah, actually, this is a advanced version of Axis of IQ. IQ platform is there for the last 15 years, more than 15 years. I think 2005, if I'm correct. It is 2005 they have launched this Axis of IQ, and since then, like it is one of the top premium IOL in that segment. And now, like this Clarion has come up, it is a modified version of this revolutionary Axis of IQ. And what they have done is they have added HEMA to the hydrophobic material, and that actually reduces the glistenings and surface haze, as well as the subsurface nano glistenings. So thus it enhances the quality of vision. The lens is a clear lens, and the dysphotopsia is significantly reduced. We have done a study in our hospital. We have implanted close to 80 Clarion lenses, and we compared it with the Axis of IQ. There is a difference in the quality of vision. But I think that's the way to go. And it has got a special edge design that is called precision edge design, which actually reduces the edge glare, and it decreases the PCO rate. That is actually, again, there was a comparative study between Clarion and Axis of IQ. the PCO rate is around 1.5% in Clarion, which is around 2.2, 2.3 in accuracy of IQ over 3 years period. So there is advantage. I think that's the way to go.
No, I also believe that on the Axelrod platform, they have this, what they call as a 6 millimeter usable zone. Now that the high refractive index lenses, that the larger zone, they do away with those other IOLs which have this non-reflecting elements in the periphery. So there's a larger area of light going in. And of course, that some kind of a lateral wall of the optic, they have created a curvature, which is called a precision edge design. Unlike the truncated square edge, here it is the posterior surface edge. So the reflection and the transmitting lights are done away with. So that's how they claim. One, with the glistenings being done away with, the precision edge design, and the large usable central optic zone, all put together. So I think it is each of these lenses, I mean, let's be unbiased. There are a whole lot of other lenses which are also good. But what is most important is that when we are implanting a particular lens, it enriches us to know the values of each of these lenses, and that helps us to decide what to do for which patient, when to mix and match, and how to go further. It goes without saying again that the stable force haptics of these Clarion or Panoptics or Vivity would also further enhance the rotational stability, and the fibronectin allows it to get adhered to the posterior capsule. So it would be a great platform to use for a toric IOL too. So definitely
I think,
these are good lenses.
We are now waiting for a Clarion toric lens, given the understanding that this is going to be the platform of the future. And I think we've had a great session, Chitra, with excellent moderation and fire ranging from your side for all the surgeons. And we would like to have the whole team there, and would like to thank everybody for excellent surgeries, and more important than that, excellent discussion. I think there's nothing left which we did not discuss. So thank you so much, Dr. Ramamurthy. Thank you, Shreyas, Chitra, and Shrish, all of you. And thank you, Alcon, for hosting this show under the aegis of Aios. And of course, Dr. Rajesh, audiovisual team, and our office back at home, Mr. Kripal. So
I just would like to add one sentence. 3 excellent surgeries and a very good moderator. I would like to thank Eye Foundation for
extremely flawless.
Doing a wonderful job.
Yeah, completely flawless. And your OT is just wonderful from whatever we could see.
Namrata and Rajesh, truly appreciate your moderation. Thank you so much, Namrata and Rajesh. I mean, truly appreciate your moderation and all the inputs that you gave. And thanks to the team Alcon for making this possible. And thank you, Aios.
Thank you.
And thanks a lot, Namrata and Rajesh, for such encouraging words, which I think all of us would go back feeling so happy today. Thank you so much.
From the
I must thank
madam.
you, and would like to congratulate you for your energy levels.
Congratulations to all of you, and thank you so much.
Thank you. Thank you. Thank you.
Thank you.